Good morning, everyone, and warm wishes from me. I'm Dr. Sudhir Sapkota. I'm a pediatric hemato-oncologist working in Kanti Children's Hospital. Good morning, good morning, everyone. We're in Kathmandu, and good evening to all in Canada. Hope many of you have already got the vaccines in Canada and abroad, and in Nepal, we'll be getting the vaccine soon. And best wishes for your first jab. Today, it is the second session of the Eco Palliative Care Nepal Part 2. Before we enter the session, let me remind you about the Zoom session. Please enter your name in the in your user ID, as I have noted out few participants who have been noted with their own mobile name, so there will be issue while taking the attendance. And also, when you are not speaking, please kindly mute yourself. For today's session, the topic is anxiety, grief, and bereavement in children. And for the host will be Saskriti and Chalk. Key learning points after this session will be collated by Rupa Mahajan. And for any queries, you will be provided time and you can talk. We can ask the question directly at the end of the session. And in the meantime, you can always put your questions in the chat. So Dr. Megan and Savita Panti madam, they will be there looking after the chat. Sunny and Saskriti, they will be the timekeeper for today. So without much further delay, I'd like to start today's presentation, and I would like to welcome Isha, who is the clinical psychologist working in the Kanti Children's Hospital, and she's also one of the member of the pediatric palliative care team at the Kanti Children's Hospital. So I'd like to welcome her to present a topic on anxiety, grief, and bereavement in children. Over to you, Isha.
Thank you, Dr. Sudhir. Thank you for the introduction. Good morning, everybody. Dr. Sudhir, could you share my slides, please? Although today's topic is on children, I'll be touching slightly with caregivers as well, because children don't occur in isolation and caregivers are always with them. Dr. Sudhir, next, please. Slideshow Pani. Okay, so the contents of my presentation today is an introduction to introduce why it's important in children with long-term hospitalization, what anxiety is, anxiety and depression, themes of anxiety in different age groups, what age-appropriate information is, what grieving, mourning, and bereavement is, questions on how we could respond to children so that it's helpful, parents' point of view, the 5 stages of grief, symptoms, and treatment of grief. So I've chosen to speak about long-term hospitalization because in most palliative care, children in palliative care, there is long-term hospitalization and the prevalence of mental illness is very high. And when emotional and behavioral problems persist, they can impair day-to-day functioning. It could affect adherence to medical treatment, causing relapse and hinder optimal recovery. And if we incorporate an awareness of these problems with children and families and healthcare providers can then minimize potentially traumatic aspects of medical care, identify children and families with or at risk with persistent distress, and provide anticipatory guidance to help prevent long-lasting traumatic effects. So if we look at this table, you can see depression and anxiety is very high in cancer and burn patients. I couldn't find the data for surgery because surgery is very specific to different surgeries. And PTSD is high in all. Traumatic stress for any child with injury or with significant level of injury is about 80%, whereas the traumatic stress reaction for parents is slightly lesser with 20 to 30%, and for siblings 15 to 25%. And these symptoms could affect day-to-day functioning. So, speaking about anxiety now, it's diffused, unpleasant, vague sense of apprehension accompanied by autonomic systems. This means that you know that you're aware of being a little stressed, a little nervous, along with different actions happening in your body, which makes you very uncomfortable. So, the difference between fear and anxiety is fear is something that is of real danger, whereas anxiety, it's not as dangerous, but it blows up in your mind of being potentially as dangerous as anything that we would fear. Anxiety is actually useful to us. For instance, it alerts our system. So if we're crossing a road and we can hear a vehicle coming right at us, our body is prepared for immediate action and then we run to the other side. This is because we're anxious and it makes us more alert about our surrounding. Uh, so when you're in anxiety, you have a sense of dread and you have different bodily manifestations. You could have a headache, it would be difficult for you to breathe. Sometimes you have blurry vision, dry mouth, you feel that there's something stuck in your throat. You might your heartbeat might increase, you might have pains and aches in your chest, limbs, stomach, back. You might tremble, you might feel dizzy, faint, wobbly legs. You might sweat even when it's not cold, and you may feel weakness throughout your body as well. So, depression and anxiety, they share a lot of common features, and when one of them occur, there will be some symptoms of the other as well. So, the symptoms that they share is being restless, excessive worrying, and agitation. Besides this, I've already spoken about anxiety. In depression, you could be frustrated, sad, you may feel worthless, irritable, you may not enjoy doing anything. You may have multiple negative thoughts and thoughts of self harm or suicide. You may feel tired and you may have disturbances in your sleep and appetite. Except that you may have your self esteem might be affected, having low self esteem, as well as concentration and attention may also be affected. And I've chosen to spoke about both of these because they're very common in children in palliative care. Next, please. I can't see the slides anymore. Uh, I have a hard copy of my slides if I should use it. Should I use my own copy, Dr. Sudhir?
Sudhir, do you want me to share them? Are you having, it's maybe not good connection?
Thank you, Dr.
There we
Sudhir.
go.
So themes of anxiety varies according to the age group. For someone from 0 to 2 years of age, they worry about what's happening right now. So separation anxiety is a theme of their anxiety. For maybe school-age children from 6 to 12 years, they miss seeing their classmates. Loss of normal life is very difficult, and they may have a lot of guilt feelings that they caused the illness, and they would have problems with returning to the school bald or with burn marks or amputation, etc. Whereas for adolescents and teenagers, they'd be they would be it would be difficult because of disruption of their school as well as changes in their appear, fitness, self-esteem, body image as well. They've just found independence and they feel that their independence is threatened. Sometimes they could feel embarrassed and upset about what has happened to them, especially if the treatment has caused side effects to the way they look. Most of these children are guilty that something has happened to them and that they're spending their parents' money, and they could sometimes think themselves as the problem and burden for their family. They themselves don't understand what's going on and why so much of surgeries and medical procedures is happening to them. So age appropriate information is very useful because it helps us decrease their anxiety levels. If they know what's going on and coming up in the future, it would help them. So for 2 to 5 years, you just give them simple examples, simple information like name of their illness and that it's not contagious, etc. Whereas for older children, their ability to grasp is a little higher. So you'll tell them name, how it'll be treated, and what's going to happen with other activities like in school, what's going on with their siblings, etc. Whereas for teenagers, it will be beneficial if the team of healthcare providers themselves give them information, a little more information. With all these children, it's very, very important that we ask them what they're thinking. And for that, we can talk to the parents also, because then we can answer their questions. So defining grief, it's a subjective feeling precipitated by death of a loved one. Mourning is the process by which grief is resolved. It's the society's way of helping us grieve. And bereavement is the state of being deprived of someone by death and refers to someone in the state of mourning. Sometimes when we're undergoing grief and bereavement, the person looks as if he's in a depressive episode. So you should always be able to differentiate. So after 2 months, if the person still is preoccupied with worthlessness, suicidal ideation, or psychotic symptoms like you hear voices or you can see things that are not there, or psychomotor retardation, where movement of your body is a little slow, the way your speech is slow, the way you respond to any stimuli is slow, then you should definitely refer that person to a psychiatrist. Otherwise, having a few depressive symptoms is common after grief. So, like I said initially, loss does not only affect the child, it affects the child's environment, parents, siblings, school, friends and family, relatives, everybody. Thank you. So, I'm going to talk about one of the perspectives of many of how to respond to children when they say things. What would be helpful to children? When it comes to children, people are very uncomfortable sharing things about death. They try not to talk about the disease in front of the children. So a child never really gets space to talk about them. So talk to the parents and find out what the child thinks or what the child is asking them. So if a child says, "Will I die?" you can tell them you're very sick and you are under treatment. We will do everything to make you feel better. Sometimes this is not enough and they might ask more questions. For that, answer gradually. If you don't know how to respond to them, tell them you'll come back and respond to them later. Next, uh, if a child asks, "Where do we go after we die? Can we come back?" you could respond by saying, "When people die, they do not come back. No one is sure about what happens to people who die, but we all believe different things about it. Some believe that dead people go to God or to heaven. Some believe that they become tree or flower or a cell. What would you believe?" And go with whatever the child says that he believes, because that would be more real for him. And also depends on what he's been told or what he's been hearing from when we're small. Next, will I also die when I get sick? You give the same response saying that you're sick. Doctors will do everything they can do to help you feel better. And if they ask something like, "In my condition, if somebody else is there, do they live?" then give them realistic information. Next. So sometimes they may ask, what does dying mean? Because they don't understand and nobody has taken the trouble of explaining it to them. So you can take an example of these flowers, that there are two flowers here and one is alive and one is dead. The one that's alive can drink water, eat food, and it can blow when the wind blows, so it's alive. Whereas the second one, it cannot drink water or eat, it looks all dried up and cannot move. People are like that too. When they're alive, they can breathe, walk, sleep, eat, etc. But when they die, they cannot do any of these things. So they cannot even be in the same place as people who are alive. Some people also believe that they're like plants and flowers, people also become mud. And then elaborate on whatever more the child asks. Next, children would have heard about spirit or soul. So to explain this, you can say that people are also, or spirit is also like a rose. It has fragrance. You can feel it, but you cannot see it. Spirit is something similar. You can feel it, but you can't see it. Children feel guilty for anything wrong happening because they can't fully comprehend what's happening, and they usually blame themselves. So if the child says, did X go away because she was angry with me? Maybe I did something wrong. Always work on their guilt. It's very essential. So you tell them that it's not because she was angry with you. You're not responsible for what happened at all. And X would never think that. If it's a mother, we can also add by saying that she loved you very much. And sometimes things happens in ways we don't expect, or illness or accidents do happen. So always work on their children. If a child is a little older, you can ask why they think that, what makes them think. If they're from language, if they're able to say 6 years or above, it's relatively more easy to talk to them. So reason out with them according to what they understand. Thank you. Next. The slides have gone. So responding to adolescents, why did this happen to me? Adolescents usually, for a lot of, next slide please, for a lot of situations, their primary concern is why me? Why did this happen to me? So at that time, you can respond by saying that I understand that what has happened is not fair, and it is all right for you to feel angry. In addition to feeling sad, nothing you did caused it. Sometimes things happen in a way we do not expect, whether they're illness or accident. So adolescents are more verbal, so you ask them. Sometimes they are more hesitant to respond and interact compared to children. It's very important that you have a very good rapport for them to be able to talk to you openly. Next slide, please. They may say, why should I live? I don't want to live anymore. At that time, you talk about their future plans and what they want to do, their dreams, so that they have a motive that, they want to do all these things. So that's a little more reassuring and a little more something like life has meaning to them kind of thing. Thank you. Next slide, please. So how to help children? Children usually have no space to grieve. Even in the clinic, I've seen children who know that somebody's passed away, but after that person's rituals are over, they've not heard the person's name. And all the adults also hesitate talking in front of the child, thinking that it will have a negative impact on it. But it's very important that the child hears the person and talks about it. So to hear the child's narrative, there are a few reasons why it's important, so that we understand the child's unique experience and perspective, so that we validate and acknowledge the child's emotions, and we understand the nature of the loss in order to plan future interventions for the child. Uh, Next slide, please. So artwork is very effective, especially with children who have limited language skills. Drawing can be a way of releasing their anxiety and what's going on in their mind. So we can ask them to draw a picture, and then we can ask them questions that are useful, like, who is this? What is happening? How was this person feeling? What happened before that? Or how are you feeling? What comes to your mind when you made this picture? And things like that, so that they're able to ventilate what's going on in their mind. So next question, please. The next slide, please. So this is an image by a child. I found it online. It's about the child and his mom, that both of them are in heaven. But looking at this picture, different, all of us may see different things. Like when I looked at the picture, I saw, okay, in the future when the child passes away, the child's going to be with his mother. Someone might say, no, the child wants to be with their mother. So talking about it and understanding the child's point of view is very, very important. Next slide, please. So there are times when there is no opportunity to say goodbye. Supposing you've lost a loved one in an accident or something. So at that time, you could ask the child to write a letter to say a final goodbye, so that they're able to say everything they wanted to, and they get an opportunity to say it. Let's let it out of their mind and their hearts. Next slide, please. Sometimes for a child whose language is not very developed and does not have writing skills or something, you can tell the child to close their eyes and imagine the therapist is their mother and then talk to them. You could also respond to something that's comforting and reassuring to the child, so that everything that the child is facing, the child lets it out, and then intervention further is more easier. Next slide, please. So even if a loved one passes away, it's always helpful to remember someone, maybe by lighting a candle every day, or diya in our context, to draw a picture and look at them every day, think of them. You could also think or remember them using useful, good memories. That would be very helpful to the child. That would bring the child a little bit of happiness, etc. Next slide, please. Okay, like I said, children don't live in isolation. They always pick on how parents are feeling, and then they start thinking. If the parent is perpetually sad around the child and the child does not explain what's going on, it would be more anxiety provoking than sharing the information with the child. And with the parents also, you have to share all the information with the parents. Like the last week's presentation, breaking bad news using the spikes model is very helpful. When we talk about loss, it's not only loss or death of a child, it's also loss of a healthy child. So when you break the news itself is very difficult for the parents. The culture in different cultures helps you grieve. Like we have 45 days in Buddhism, 13 days in Nepal Hinduism, but that's not always the case. Grieving lasts for a very, very long time compared to that, and continuing normal life could be difficult. It could take years for some people, even if it's not very complex. Just losing a child can be a very difficult experience, and memories could be difficult for a few years also. Next slide, please.
Excuse me, ma'am. We have 5 more minutes.
Okay, thank you, Dr. Sudhir. So, parents, there are 5 stages of grieving. That's denial, anger, bargaining, depression, and then finally acceptance. Denial is usually when you tell them their diagnosis. Sometimes parents say that, okay, I want a second opinion, to do multiple tests. Sometimes once the diagnosis is made, they go to India for the same. So it's very difficult to accept that something serious, life-threatening happened to their child, and that there are chances that they may lose the child. They may be angry, trying to understand why that happened, and sometimes may blame themselves, or may say that their fate is bad that this happened to their child. Bargaining, they always ask for a little bit more time, saying that I'll do anything. How can we save the child? Like there was a child, admitted in Kanti whose whole body under the neck was going to be paralyzed, but the parents still wanted to save the child, and that was the most important for them at that time. Depression, they feel depressed about what's happening, and finally, after they overcome depression, then they accept it. This 5 stages was used. Next slide, please. This 5 stages was. You can turn on to the next slide. So the 5 stages that I just spoke about is for someone who knows that it's going to die, but then it's also for knowing that something bad's going to happen to someone so close to you. So in grief, you can have physical, behavioral, and emotional symptoms. Physical symptoms very close to what we discussed in anxiety. Emotional symptoms can be sadness, anger, guilt, anxiety, and loneliness. And behavioral symptoms can be forgetfulness, worrying more about others, prolonged withdrawal from normal life activities, where even if they try, it's very difficult to integrate to how life used to be. Next slide, please. They may question their purpose of life or spiritual beliefs, saying, why did God do this to me? And they may have multiple behavioral changes, making it very difficult for them to cope with their life. Next slide. So treatment of grief, there are support groups and bereavement groups. I think not in Nepal, but that could be very helpful for parents. Even individual counseling can be helpful, whether for parents as well as children. And sometimes you should always refer if grief is causing obstacles in a person's daily life, functioning of daily life, as they're not able to do things they used to do before. And grief, like I said, you can't cure it. It just takes a lot of time and coping strategies, but individual therapy or counseling could definitely help the person grieve. Next slide, please. It's easy to say that time heals, and it does also, but it takes a lot of time and it's very, very difficult. It's important that they're able to speak about the incident of what happened and remembering the time it happened, as well as remembering the good time. Usually after breaking the news to the parents and when they are sharing their experience and everything, there are long pauses and you just have to work with the silences. You can give them time, you can go take therapy slow, but you have to work with the silences of the parents, going at a pace they are comfortable with. And it's important to know that they did everything they could, especially in palliative care, because they're in treatment for so long. The parents usually do everything that was possible for them. I think with this I've come to, can we see the next slide? Okay, yeah. So there is let's not see the video. I think it's going to take time if you see it. So there is a website called makeawish.com, and children who have life-threatening conditions, they make their wishes come true. I think last night I was seeing a Indian version of it, and there was the girl who wanted to wear a princess dress. There was the boy who wanted to meet Sachin Tendulkar, and a boy who wanted to be a cop. So everything was provided to them. The boy who wanted to be a cop, he actually had a costume of a police, and he was sitting alongside them. And you can really see the excitement and the happiness reflects through on their face. Okay, I think I have one more slide left. Quickly go through that. Okay, the last slide would have been the take-home message. So it's very important to give children information that's age appropriate. Grief is very difficult for everybody, but if their questions are answered, it becomes relatively easy for the child. Even for the parents, being there for the parents is very important, and always let the parents know, even if they're at their final time, we are always there for the parents. Should I, Megan, do you want to go next? Or should I answer the questions?
Thank you, Isha. Thank you for a wonderful presentation. We'll definitely take the questions, but at the last of the session.
All right.
And, thank you for a wonderful presentation, and you have beautifully answered many of the questions that we were unanswerable. We were wondering what to reply to the children, and you have given us insight how a child feels and during anxiety and grief. Really, that has been a great help for us and for our participants too. So we'll be taking the questions at the end of this session, and in the meantime, other participants can put up their questions in the chat. And now I would like to introduce Dr. Megan. She'll be talking about supporting children with illness and grief and loss. And I don't think she needs any introduction. She is the one who has conceptualized all this program, and she is always there supporting us, even sharing these slides when there is some technical problem. So over to you, Megan.
Thank you, Sudhir. And I want to say, Isha, it's an honor to present with you. And you are really, really an excellent resource for the team in Nepal. I think I want to emphasize for all of our participants in Nepal that you are very, very fortunate to have the resource of Isha and Rampukar. In many places, we don't have the kind of resources, have that expertise of the psychologist. So it's incredible. And we're so lucky to have you share with us. I really thank you. And so I'll share with you a little bit of my perspectives as a physician, how I take the expertise from the psychologist and implement it a little bit into my own practice in terms of how I interact with the patients. So I think really what my thinking was is to complement what Isha has said and just a little bit discuss what actions can we provide to children to give them the support they need with these experiences of serious illness, of death, of grief. And I think of it in a very simple way. Obviously, it can be thought of more complexly, but I really always think, okay, children communicate with me as their physician in three main ways. Of course, we all know they communicate through their words. And we're good as adults, we're very good at using words. But we also have to remember how much our nonverbal communication is showing children that we want to talk to them or that we don't want to talk to them. And our nonverbal communication gives children a lot of clues about if we're the kind of person, the kind of doctor, the kind of nurse, the kind of counselor who is open to hearing and talking to them. And they're watching even when you're talking to their parents. And they're watching how you look at them. I love this picture because the doctor in this picture is, you can tell there's a connection with this child. They're like the way the little boy is looking and the doctor is having eye contact with them. This is really important for us. If we don't look at them and make the eye contact be at the same level as them, then often they won't talk to us, right? Sometimes we go in and we say, oh, this child's very sad, they're very quiet, they're withdrawn, they won't talk to us. And it's up to us to learn those strategies. And it's very, we can learn how to really get up so we can support them. And the third way that children communicate, which I learned so much about when I started doing palliative care in Bangladesh, was through play. And this is a picture of a tiny little play closet, playroom that we had in Bangladesh. And we had just a few toys, but it was this safe, clean, quiet place just on the veranda of the ward. And they could come there when they weren't needing to get treatment. And they could just be children and they could just be free. And it was such a safe and wonderful place for them. So there's so many benefits to play. And I know we've had lots of discussion about play in our first echo, but I just want to emphasize how much play is part of children's ability to cope. And when children are very sick, they need the ability to play. They need to be encouraged to play. They're scared in hospitals, so they don't want to play. So we have to help them with that experience of needing to play. This is a very simple way of thinking about how a child might understand their illness. So they might start from a place of this first step. I was previously well, but now there's something very wrong. And we know we should use the correct word for their illness, if it's cancer or cerebral palsy or whatever the problem that they're having is, so that they can understand and they can ask questions about it. As the child gets sick, they might know I'm seriously ill, but at first they assume, or we will probably be telling them, but you will get better. There's a treatment, the doctors will help you. Over time, as they maybe have relapses or more treatment goes on, they may come to step 3 where they think, I'm always ill, but I might get better. At some point, they may realize, or we might need to tell them that I'm always ill and I will never get better. And at some point, children do realize that they are dying. And I think this often happens for children in our hospitals because they see another child pass away who was on the bed beside them, or they know a child who was a friend and they hear that that friend is not alive anymore. You know, it was a child that they played with on the ward. So they quickly can come to that understanding that there might be a time when they pass away. And there's 4 common concerns that I always find it helpful to tell parents that children will have about serious illness and potentially death of themselves or usually of a loved one. So this might be something to talk to the parents about so they can think about the other children in the family, the brothers and sisters. The children will want to know these 4 C's. Did I cause it? Can I catch it? Could I have cured it? They want to know, could we do anything different to make it better? And then if it's a caregiver, they're worried, who's going to take care of me, right? Children are egocentric. And so it's important that we reassure them that there will be somebody to take care of them. No matter what happens, we will make sure they're cared for. And that applies to the child who's dying as well. A big worry for children when they're dying is that they will be alone. We often get asked the question, and I often get asked this question by my colleagues, at what age should we tell children if they are dying? And I think this isn't necessarily, the question is framed in a way that is tricky and it confuses us sometimes. Instead of saying at what age, should they be 5, should they be 6, we should be saying, what does the child need to know? What do they want to know? How are they doing with what they understand about the illness? And if you have those good conversations with the child, you can help answer their questions. And maybe their question is, am I dying? But not all children have that question. So we have to have the child lead us. Instead of us thinking, what do I have to tell the child? We think, what does the child need from me? And what questions does the child have? And this is because parents are often very hesitant to tell a child about their illness and its prognosis. We all know that in every culture in the whole world, parents want to protect their children, and they feel they protect their children by not telling them things sometimes. But we know that that's not always the best idea, that children get support from having the information that they need. And when they don't know things, they get more anxious. Another key point is the second bullet here, that it's important to support a child by having one person who forms a trusting relationship with the child. And through that relationship, they can explore the child's well-being. This might be a social worker or a recreation therapist, a child life specialist. It could be a family member. It could be a doctor. It could be a nurse. For every child, we try to have one person on our palliative care team who we know is investing and is connecting with that child and understanding and exploring their child's questions. I think Isha has done a really nice job of talking about how children express grief, how children experience grief. I want to emphasize a couple key points in my last couple minutes. And one is that grief is very different for children, young children, than for adults. Grief depends on how old and how much development the child has. And at each developmental stage, the child has to re-experience the loss. So if the child has a brother who dies when the child is 4, then the child experiences the grief as a 4-year-old. Then when the child becomes 6 and 8 and 10, at each age, the child will have a new experience of that grief because they understand differently what happened. There's a good video here about how children experience grief at different ages. And so there's a nice link. I won't show it, but I recommend it. It's nice and short. It's just 2 or 3 minutes. And sometimes the grief experts say that for children, the process is not linear. They don't always go through those stages of denial, bargaining, depression in a linear fashion. They do puddle jumping, where they have little puddles of grief, and then they feel okay and they're out of the grief for a period of time. So they might be distressed and grieving, and then they might just seem happy and playing normally. And it's unique for each child. The advice that we give for the parents is to encourage the child to ask questions, and the parents should try and find the answers and take advice from the doctors, the nurses, the counselors, the psychologists to help answer the child's questions. Using books and websites can be very helpful for parents who don't know how to explain it to their child. Because sometimes children, it's really hard for parents to say the words. So if they have a storybook they read the child, then sometimes they can say the words better through the story. We encourage parents to share their grief with their children so the child is comfortable sharing the grief openly with the parents. Including the child in the family's grief, including the child in the rituals around death and bereavement, funerals, can be okay. Parents think that if you include the child, you're going to damage the child emotionally, but I encourage them to take the child into the rituals that are appropriate for the culture. Reassure the child that feelings of grief are normal, everyone grieves, and encourage the child to express themselves in all those nice ways of drawing, of play, of words, talking that Isha described. Here are a few of my personal favorite grief resources. I looked at a lot of resources when I was doing some course writing in Canada. Unfortunately, they're all in English, but the links here are good. The Sesame workshops on grief have like the Sesame Street characters, and there's one series on grieving where one of the characters dies. There's kidsgrief.ca, which is very good for parents and I would encourage you all to look at it. And here are some of my favorite books about grieving that we sometimes use to read to children. The Invisible String and When Dinosaurs Die. So those are some that I really recommend. I don't know if there are any in Nepalese. And here's another example of sometimes, you know how I said kids won't talk to us? Here's an example of an activity we sometimes do. It's a little bit messy. You should not do it inside. We did it inside. In hindsight, you should do it outside. But they take the water balloons. They take balloons and they fill them with water and some paint. And some they put red paint and water and some they put blue. And the red is for emotions that are maybe difficult and hard and they may be negative emotions like being angry or sad. And then what the child does, they take the balloon and they're going to throw it against the ground and smash it. And at the same time, they say how they're feeling. So they might say, I'm feeling mad because my brother died. And they can do that with the red ones and they can do it with the blue ones. You can use the blue ones for maybe a different type of emotion, like sad emotions or, you know, good emotions. You can choose how you want it to do. But sometimes just by throwing something, then they can talk and they can shout out what they feel. Otherwise, they don't want to talk. So we've done that a few times outdoors after the first time. And there's more resources here. Again, we'll share this with you after about how to talk to children. These online resources from the BC Children's Hospital Library are really good. They're free handouts. They're in English, but they talk about how to talk to dying children, how to talk to siblings, how to talk with family and friends. They're for parents to read, but they're really good for healthcare professionals as well. And then all of the videos on the website called Virtual Hospice, which is a Canadian website, Kids and Grief, How Children Grieve, Parenting a Child Through Death and Grief. All of these are really good little short videos on the website. So I'll summarize there. That's my last slide. Just the things to remember. Children can communicate in 3 ways: verbal, nonverbal, and play. And the child's developmental stage and their age is going to influence how they experience the grief, experience the serious illness. And children need the opportunity to explore their illness, their worries, and their fears with someone that they trust. And that might be one of us. So it's very important that we feel open and ready to have those conversations.
Thank you, Dr. Megan, for such a simple presentation, and she has quietly focused on the non-verbal communication and the expression of the grief and anger through color demonstration. That is definitely helpful, and maybe we can adopt it in our setting also. Now I would like to welcome Asta Sahi, and she will be having a case presentation, which will be similar to the topic that we have discussed. She is the hospital nursing staff and working at the pediatric hemato-oncology unit in Kanti Children's Hospital. Over to you, Asta.
Thank you, Dr. Sudhir and team. I'm here to present the case. Let's begin. Key question for case presentation: anxiety, grief, and bereavement in adolescent as well as parents. Multidisciplinary approach for management of complex situation and during bereavement period. Psychological counseling for adolescent and parents. Next, please. Patient details: a 13-year male child with diagnosis as acute myeloid leukemia relapsed on 2020 June 6th. Next, please. Treatment and significant investigation. Flow cytometry was done and the report was acute myeloid leukemia. Latest investigation was hemoglobin 7.6 gram per dl. Platelets count was 28,000 per mm3. WBC count was 5400 per mm3. USA abdomen was done and it was normal. CT scan of brain was done, it was also normal, and echo was also normal. Pain and symptoms, including relevant treatments. Paleness of body, petechia, and purpura of skin. For that, we transfuse packed red blood cell as well as platelets concentrate. Weakness and fatigue. Low-grade fever for continue 1 week, 101.4 degree Fahrenheit. Treatment: IV antibiotics, injection paracetamol, TDS was given for low-grade fever. For severe body pain, injection morphine, QID was provided. For nausea and vomiting, injection onlestrom, TDS was provided. For mucositis, betadine oral gargle, candid mouth paint, and topical gel, oral gel was applied to the patient. Communication. The child belongs to adolescent age group, so he was aware about the disease and procedure that are carried out. He was single parent. Only mother was taking responsibility of the child for the treatment. His father expired 6 years ago due to road traffic accident, so so financial support was very low. Parent was well known about diagnosis and its prognosis, but reluctant to disease the child. The child discussed about the child discussed about his disease condition with his mother and nursing staff, thinking that it will help him to reduce his anxiousness. Next, please. Continue. Mother is housewife and he has one elder brother. Permanently, they live in a rural village where his siblings are being cared by relatives. He used to live in a rented room nearby hospital for treatment with his mother. The family was facing financial hardship. They are they have no any health insurance and already in loan for child's treatment. They are concerned about how to manage complication and face the challenges. Next, please. Psychosocial and family concern. We provided psychological counseling after relapsing the disease to the mother, so she was worried about the child's condition. Child was not communicating with others. Child's physical symptoms was also adding more to the grief to the family. Mother was in grief every time, especially during the procedure or medication. So further psychological counseling was done to the mother and child, as well as supportive treatment was provided to the child. Later, when patient was expired on PICU at that time, we visited to the mother and other family members and provided emotional support. Next, please. Spiritual concern. Family has faith on God, Hindu by religion. For the condition of the child, they are blaming their own faith. Next, please. Collaboration and partnership. Collaboration with rural municipality was done to receive government health insurance. Psychotherapist counseling was done for interaction between child and mother. As the child looked very sad, anxious, and depressed during first hospitalized days, several meetings with psychotherapist was arranged to reduce his negative thoughts and to manage his stress level regarding treatment. Arrangement was done for financial help. Next, please. Summary of the case. A 13-year-old male child with acute myeloid leukemia relapsed who developed mucositis, body pain, vomiting, headache, and fatigue during the later phase. Palliative care started and involvement of the family in all the aspects of care was done. Family facing psychological and financial hardship. Multidisciplinary approach was provided to the family members. Next, please. Key question for case presentation. Bereavement counseling to the family members. Can the situation be handled smoothly? Use multidisciplinary approach during the period of counseling. What else could have been done? Emotional counseling for the mother and family members. Is it effective? Thank you so much for listening me.
Thank you, Asta Sai, for your nice elaborative presentation. And as they have also provided the good bereavement support, which is not that common in our setup. I feel that they have really managed the patient well, in addition to the symptoms and the psychological aspect that has been managed for the child. Now to go for the question, how to handle the, she has raised the question how to handle the case even more efficiently and more smoothly. Uh, and Dr. Peter, are you there with us?
Yes, I am, Sudhir. Sorry, I'm dealing.
We can't hear you, Peter.
Can you hear me now?
Yeah.
Sorry, I'm just dealing with another work issue on the phone right now, so I didn't hear that last part
Okay.
of your question.
I'll pass it to
someone else, please.
Yeah, I'll pass it to Kamara.
So, I mean, it's so complicated. I think when we hear such distress from the children and from the families, about how do we handle this more smoothly. My little bit of advice is just how do we settle in and talk? How do we be curious about what is happening for the child or for the parents? So if we can, as staff, take a moment to say, tell me more, tell me about what you're worried about, tell me how I can comfort you. That is a small thing we can do that makes a huge difference. There's a really lovely quote about we don't remember what people say, but we remember how we're made to feel. So if you can bring in the comfort of sitting with and being with a child or a parent when they're in distress, the reality is we cannot fix dying. What we can do is be with. So that's what I would offer today.
Thank you, Kamra. Definitely. Unless not only speaking, we should be doing something for them also. So that would be more touching for them. Any from one from the faculties, Megan or Natasha would like to add something. What else could have been done in this scenario? They have managed the symptom well. They have done the counsel. Still, there can be some point of improvement. What else could have been done in this case? Maybe to
Hi, Sudhir.
yeah, Natasha.
There's Natasha.
Yeah.
Yeah, as you know, I think as Kamara said, it's hard to know in the moment what to do differently. I think as a pediatric oncologist and palliative care doctor, I can sometimes see both sides. And I think one of the things that I always wonder about is just being able to be. So I think sometimes being able to be silent with a teenager, especially in a room, can sometimes just give you a lot of information about what they're feeling. And I think that's really hard to do as, you know, the doctors and nurses who are busy on the ward. But, you know, we do have moments where, you know, palliative care can be done by anybody, right? Good listening and supporting and providing comfort and compassion and love, right? We treat others as we want to be treated. And I think we're all here because we want to learn about that. So I think that just knowing that probably a lot of the nurses and the team around this child and family did a lot of that and didn't maybe realize that they were doing that. So just being aware that even if you're going in to give a medicine or do your ward rounds, those moments, just taking a little extra minute or second to really just be with the child or family, I think speaks volumes and can really benefit the child. And I see that as an oncologist and palliative care team member. So I think people also need to give themselves credit. I think probably people did a really good job in the situation they had, but just remembering that giving those extra few moments of silence or just sitting with the child really goes a long way, and anybody can do that.
Thank you, Dr. Natasha, and she has highlighted that we need not have a separate setting to have the counseling sessions, and definitely when we are there to give the medication or when we are there to look after their reports, in that time we can say few words to them, just we can have one or two additional minutes, so that will be more efficient than having a separate counseling session each and every time, which may not be possible. So that's a nice recommendation. Any other thoughts? Dr. Krishna, would you like to add something?
Hello? Yeah? Hello?
Yes, please go on.
Yeah. Thank you, Isha, for the nice presentation, and input from Megan is very important for our experience and the resources, obviously. So this is very good, but it's always difficult to have the children in the ward seeing the other child is dying, and then he takes a few days to recover. Normally also he pretend like he's normal, but he's lots of grief and pain, panicky for a few days. Even he's scary to sit in the next to the bed, and it is not always uh, easy for us to separate him when some child is dying. Somehow he see it, he see his parent, and even other child. Sometimes they won't stay whole day, whole night on the same next to bed. It's very difficult for us. So death and anxiety, even sometimes they went on depression. So it is very practical, and we cannot address much on this due to our working area and place, and the very useful topics, and Isha presented very well, and Megan put the light on her personal experience and resources. I think it will be very good for all of us to go through the resources and address the issue. It is very new to us how to address that. We are lots of pediatrician and palliative caregiver, but very most of the things may be very new for us, how we can deal it and how we express on it. So I think it is very good topics and presentation today. Thank you all.
you.
Yeah.
Thank you,
Yeah,
Dr. Krishna.
there is not much question in the chat box. Maybe that is very new for us, and we cannot what to express or like that. So I just try to explore in chat box. Is not that active. So there are the expert. Maybe anybody we can have in the future also. They can put some question and they clear it. Okay. Thank you, Megan.
Yeah, thank you, Dr. Krishna. Definitely, we have been less active in the chat box. Maybe this is due to cold weather, so everyone is there inside their own bed and not wishing to type. So we'll have one or two last questions from the participants. If anyone would like to have a question regarding the topic or regarding the case or any doubt regarding to anxiety and grief in children, you can just unmute yourself and have a quick question with the faculties.
Sudhir, I'm going to be doing a talk on play and in a couple weeks. So I would love if anyone had a question that I could think about and put in my presentation in a couple weeks. So I also invite people to put a question in now about play therapy or play with children who are dying if they had that.
Definitely, you can put the question in the WhatsApp group, and camera is also there, and she will be happy to incorporate that in our talk. So if we don't have any queries from the participants, still, if there is any query, we can put the question in the WhatsApp group from today's session, also from any session, and faculties and any other participants also will be more than happy to help each other and to answer the question and even share our experience. So with this, we'll come to the end of our today's session. Thank you everyone for your participation, and we will be looking forward for more active participation in the upcoming sessions. Today's key learning points will be reviewed by Rupa Mahajan. So please kindly send us the key learning points in 2 or 3 days time. Thank you. Special thanks to Isha, Dr. Megan, and Asta for their presentations. Thank you, everyone. Have a good day and good night to everyone in Canada. Bye-bye.
Bye.
Thank you. Thank you, Isha, for sharing so nicely.
Thank
we
you.
Thank
all
you,
have
everyone.
now
As
more
well, Megan.
Thank you.